Hi, I'm Dr. Paula Trief. I'm a Distinguished Service Professor at SUNY Upstate Medical University in Syracuse, New York, and I'm going to talk to you about diabetes and depression, or double the trouble. First, just so you can see, I have no conflicts to disclose. And this is just a picture of our campus. We're very proud of SUNY Upstate Medical University, the largest employer in the area. This is our Golisano Children's Hospital. We're particularly proud of that. We do get a lot of snow, and it is very, very cold. Everybody knows that, but it's also just a beautiful, beautiful area to live. So that's upstate. The aim for today's talk is, first I'm going to talk about what is diabetes, just to make sure that we're all on the same page and understand the language that I'm using. I'll talk a little bit about what is depression, and then I'll talk about what the burdens and outcomes are when a patient or when you have both diabetes and depression, and then what you can do if you or a loved one has diabetes and think you may be depressed. So first, a brief overview of diabetes. Diabetes is a really prevalent disease. Over 30.3 million people in the United States have diabetes. That's about 9.4% of the U.S. population. It's particularly prevalent in the elderly. And we know that every 17 seconds, someone is diagnosed with diabetes. So what happens when we eat? So first you have to know about what happens when we normally eat and when we don't have diabetes. And after eating, most of our food is turned into glucose, and the glucose enters the bloodstream and the blood carries it to our cells. Glucose serves as the body's main source of energy, and all of the cells in your body need glucose in order to live. The pancreas, which is an internal organ, produces insulin. That's a hormone. Insulin serves to unlock the cells and allow the glucose to enter them. So if you think of it as a key in a lock, it's a kind of a good metaphor for understanding what happens when we eat. And normally what happens is that the glucose in your blood stays in a healthy range because the insulin is released at just the right times and in just the right amounts. It's quite amazing how the body works. And that allows the glucose to enter our cells. But in people who have hyperglycemia or high blood glucose, these are people who have diabetes, what happens is that the glucose builds up in the blood. And there's various reasons for that, but the main one is that the pancreas produces too little insulin, sometimes no insulin at all, so therefore the cells aren't told to unlock. And or the cells become what's called resistant to the insulin. For some reason, they just don't respond to the insulin that's there, and therefore they don't unlock. And those are the main reasons behind hyperglycemia. And if you have high glucose over a prolonged period of time, you develop, that's called diabetes. The problem here is that hyperglycemia can cause serious long-term problems. And you see here a list of the chronic complications of diabetes: blindness, kidney disease, nerve damage, amputation, which is usually tied to nerve damage, heart attack and other cardiovascular disease, stroke, cognitive decline. So there are a lot of really bad outcomes of having chronically high blood glucose. We don't really totally understand the mechanism of that, but it is very clear that these complications are linked to diabetes. Type 1 diabetes occurs in about 10%, of the people who have diabetes. Most people are diagnosed when they're children or youth, although we do know that adults are also diagnosed with type 1 diabetes. And in this case, the body doesn't produce any insulin. The pancreas doesn't produce any insulin. And since you need insulin in order to live, patients have to give themselves insulin. And they do this with either multiple daily injections of insulin or an insulin pump or some other technology. Type 2 diabetes is about 90% of the people who have diabetes have type 2 diabetes. Most people are diagnosed over the age of 40, but we are finding that type 2 is also now being diagnosed in children and in teenagers more commonly, and it's becoming a real concern. And part of that is because type 2 is more likely in people who are overweight or obese, and we know that obesity is a growing problem in our youth. The treatment for type 2 diabetes always means that you have to be educated. You should be eating a healthy diet. It's not really a tightly controlled diabetic diet the way it used to be described, but it's a healthy diet, typically low carbs. You have to monitor your blood glucose, physical activity, and ultimately most people will take medications for type 2 diabetes, and many will ultimately also use insulin. But they're not using insulin in order to live like type 1 diabetes. They're using insulin to keep their blood sugars under normal, good control. Prediabetes is a newly termed condition. This is 1 in 3 American adults have prediabetes. And what this means is that your blood glucose levels are higher than normal, but they're not yet at the level that you would be diagnosed with diabetes. But if you have prediabetes, you are definitely at risk for developing type 2 diabetes. So it means that if you intervene at that point, you may be able to prevent yourself from getting type 2. So this is kind of a lot of bad news and a lot of concern related to diabetes. But there is good news too, because we can reduce our chances of developing type 2 diabetes with weight loss, with exercise and less sedentary behavior, and sometimes with medications. And if you already have diabetes, we can reduce our chances of developing the complications that I mentioned through achieving good blood sugar control through diet, blood glucose monitoring, medications, also blood pressure control, cholesterol control, regular visits to your healthcare provider, and then early detection and treatment of these complications. So what this means is that diabetes is a disease more than most diseases that's really about behavior. Type 2 diabetes is. But even for type 1, managing it is about behavior. And the behaviors are diet and healthy eating, exercise, taking medication, sometimes insulin, having regular medical follow-up, sometimes seeing various physicians and various specialists, and definitely becoming educated. And the more educated you are, the more you know what behaviors you need to engage in to manage your diabetes. But we know that dietary changes are challenging. This is the evolution of the Western male. It's not a pretty sight, but we know that we live in a toxic environment. You can see, if you look at this slide, you can see the McDonald's French fries in 1955 had 210 calories, but by 2004, there were 610 calories. And we get pizza that has cheese stuffed into the crust and sweet things as sides, supersizing sodas. That makes it extremely challenging to change our diet. And this shows the evolution of our work life. We lead much more sedentary lifestyles, and that also adds to this challenge. And we also have a toxic environment in terms of activity. We take escalators, not stairs. This picture on the bottom here showing somebody walking their dog in their car, I think is quite comical. But the message here is always typically been to avoid physical activity, and you can get through your life pretty well without having to be active. So that makes it quite challenging to make the changes that we need to do to manage diabetes or to prevent diabetes. So that's a primer on diabetes. Now, just quickly, what is depression? Mostly here I'm talking about major depressive disorder. And what you see here is a list of the 9 symptoms of major depressive disorder. In order to be diagnosed with major depressive disorder, you have to have 5 of these 9 following symptoms occurring almost every day for at least 2 weeks. They must include at least one of the top 2, depressed mood or what's called anhedonia, or loss of pleasure or interest. Loss of pleasure or interest means if I say to you, what do you like to do? And you say to me, I love to read, but I haven't been feeling like reading much recently, or I love to walk, I just haven't been feeling like walking much recently. That means that the things that used to give you pleasure are no longer giving you pleasure, and that's called anhedonia, and that is a key symptom of depression. So you have to have either depressed mood or anhedonia, and then 4 of the others: appetite changes, eating more or less, sleep disturbance, sleeping too much, sleeping too little, being agitated or kind of sluggish, fatigued, feelings of worthlessness or guilt, difficulty concentrating, making decisions, and then, of course, recurrent thoughts of death or self-harm. Major depressive disorder is not just having a bad day. It's something much more profound. This is a little blurry, but what it says is, what is depression like, he whispered. It's like drowning, except you can see everyone around you breathing. So I think that kind of captures the real depth of the despair that people often feel when they are dealing with a major depressive disorder. So the main focus of my talk is diabetes and depression. Why do I call it double the trouble? We know that people with diabetes have twice the risk of being diagnosed with major depressive disorder when compared to the general population. Now, that does not mean that they're more likely to be depressed than people with other chronic illnesses, but compared to the general population, there is a significantly increased risk, especially for type 2 diabetes. But we also know that it's not always just major depression. We know that depressive symptoms are common, so 31 to 45% of people with diabetes report significant depressive symptoms. So not 5 of the 9, maybe 4 of the 9. maybe not anhedonia, but something else. But that is significant as well. And then there's this area called diabetes distress, which is the emotional response people have to just living with the burdens of diabetes, because it is a very challenging disease to deal with. And that causes a significantly high level of distress for many people, and that can affect your quality of life. So that's why it's double the trouble. But the most important part here, I think, is that when people are depressed, they're more likely to have poor blood sugar control. Hemoglobin A1C is a measure of blood sugar control in the preceding 2 to 3 months. If you have diabetes, you know this term. So poorer blood sugar control means higher A1C levels. If you're depressed, you're more likely to have other cardiovascular risk factors like high blood pressure, high BMI, be a smoker. If you're depressed and you have diabetes, you're more likely to have complications. You're less likely to be active in your own self-care. And as I said, this is a disease of self-care. You have higher mortality rates associated with both depression and diabetes, and very significantly higher healthcare costs. So this is really why depression and diabetes is double the trouble, because overall your outcomes of your diabetes are worse if you're depressed. So why do people with diabetes get depressed? There may be biological factors that we're not aware of. There may be changes in brain chemicals or inflammation or hormones that are associated with both diabetes and depression. Or it may be that the chronically high or low or variable blood sugar levels may result in depression. We don't really know that. But we do know that there are a lot of psychosocial challenges in terms of living with diabetes that can overwhelm us. When I think of getting depressed from a psychological perspective, I think about being presented with life's problems, challenges that you have to deal with, and we all bring our own resources to bear, our internal resources to bear on those challenges. But when your challenges kind of overwhelm your resources, you may get depressed. So what are some of these challenges? So people talk about this feeling that they have to have a careful control of their eating. This is, again, especially for type 1 patients, type 1 diabetes patients, and they feel a loss of autonomy or a sense of control over their own bodies. We know that diabetes is a hidden disease. Somebody really doesn't know if you have diabetes. And so it may mean that you don't get the kind of support that you need for managing it. We know that there's a fair stigma attached. There's stigma attached in our culture to any chronic illness. We're a culture that values being fit and healthy and youthful. And so having a chronic disease can cause a sense of shame and stigma attached to that. Also with type 2 diabetes, since it's associated with overweight and obesity, there's all the stigma that is attached to being overweight. And unfortunately, there's a lot of stigma attached to that as well. And that may cause you to hide the fact that you have diabetes. It's a disease where people talk about feeling guilty. They feel like they need to be good diabetics. And that's a phrase I often hear, I'm a bad diabetic. You don't hear that for other diseases, but you do hear that around diabetes. They feel like it's their fault, and especially if it's related to obesity. There's a fair amount of anxiety. There's anxiety about low blood sugar or hypoglycemia. Having a hypoglycemic event ranges all the way from feeling a little confused and a little off to passing out and needing to be hospitalized. So when people have a hypoglycemic event, that can be quite traumatic, and they really, really want to avoid that again, and that causes significant anxiety. Some people even keep their blood sugars high in order to avoid that experience. There's also anxiety about these complications that I mentioned, about developing them and what they're going to mean for one's life. And when people get their first complication, if they get a complication, that often is a time of significant emotional turmoil. If they have been trying hard to control their blood sugar and yet they develop a complication, they feel kind of betrayed. I did everything that I should do, and yet I still have vision problems or kidney problems. And if they haven't been in good control, they just feel more guilty. So those are periods of significant emotional stress. There may be role changes within the family or at work. There may be things that you can't do that you used to do. Some people have to go on disability, and that can cause a significant stress. And then there are the effects of the complications themselves. Some people have to go on dialysis. You might have impaired vision, impotence, pain. Those consequences of diabetes, of complications, are certainly difficult to manage and stressful. But not everybody gets depressed, and not everybody even experiences a high level of distress. So why is that? And this is what I was referring to when I talked earlier about the resources that we bring to bear. in managing these challenges. So one set of resources is what else is going on in your life. Your life is not all about diabetes. So if do you have other health problems? Is your family healthy? Is your work stable? Are you financially secure? Do you have health insurance? The reaction to a diagnosis of diabetes is going to be very different for a person who does have insurance, who feels secure, who's otherwise healthy, whose kids are doing well, as compared to, a single parent trying to raise children in a gig economy, jumping from job to job. I mean, those are very different life circumstances. So that's definitely going to affect how you manage your diabetes. And also, we know that people differ as to how we cope. There are what we psychologists would call positive ways of coping. So gathering information, educating ourselves, seeking support, making a spiritual connection, exercise. Those are all very positive ways of coping, and they're going to affect how well you do with your diabetes. But some of us tend to cope more negatively. Some of us want to deny that we have a disease or avoid the consequences or avoid thinking about it. I have patients who won't go to the doctor because they don't want their doctor to see their blood sugar readings, which are not good. And so they just avoid doctor's visits at all. Or if they do go to the doctor, they won't allow themselves to be weighed because they want to avoid the fact that they've gained weight. And that kind of avoidance makes you feel better in the short term, but in the long term, obviously it's going to cause problems. And of course, alcohol and drugs are other ways that some of us tend to cope with the stressors of life, and those, of course, are only going to make things worse. So the ways we cope are going to affect how you manage your diabetes. And then there's what we call a sense of self-efficacy, which is just a feeling that I can do it. And we all know that some of us, when faced with life's problems, have a sense of, okay, this is a big problem, but I think I can handle it. And on the other end of that continuum are people who just, for whatever reasons, tend to feel a low sense of self-efficacy. They don't feel that they can handle the problems that they have to face. And there's specific self-efficacy. So some people, when they're faced with making changes to their diet, can say, I think I can do that pretty well. I'm confident in my ability to manage that. But when you say to them, I think it'd be important for you to start doing a regular exercise program, they'll say, nope, that's not me. I can't exercise. They have a low exercise self-efficacy. So that's going to affect how they make the changes they have to make. Social support, I've mentioned kind of throughout this talk. The literature is very, very clear that people who feel supported in their lives do better. They're healthier overall, but when they develop medical problems, they have better outcomes across various illnesses, and definitely that's true across diabetes. There are different types of support. Some people may provide what's called instrumental support. They might do things with you or for you. They might drive you to the doctor's office or join a gym with you so you can exercise together, or remind you to take your medications if that's something that you want. They're helping you do the things that you need to do to manage your diabetes. Others, or maybe the same people, provide emotional support. Those are the people that you talk to when you're down or distressed or anxious, and maybe give you advice or just provide a listening ear, which is certainly very helpful. There's lots of different ways that people can provide support, but when you have support in your life. We also know from research that having a confidant, someone that you can kind of let down your guard with and really share your deepest feelings and fears, that can be particularly important. So this is not about having a large number of people. It's about having the people who make you feel supported, and that will help you with your diabetes. And then lastly, it's self-esteem. As I said, this is a disease of self-care. In order to take care of yourself, you have to think you're worth taking care of. So you have to ask yourself, do I like myself? Do I think I'm worth taking care of? And am I around people who like me and tell me that I'm worth taking care of? Because if you're not, you need to find new people. So treatment of depression for persons with diabetes, that's the same as treatment of depression for everybody. Medications, psychotherapy, education, involving the family, exercise definitely helps with depression. We know that in people with diabetes and depression that medications work, but like the general population, they don't work for about 40 to 50% of patients. There's really no evidence that one antidepressant is better than another, so your doctor will probably choose one based on the side effect profile, and especially will be looking for one that doesn't cause weight gain. Medications, when they work, they tend to work for people who have chronic severe depression. They tend to be less effective for people with mild or moderate depression. Similarly, psychotherapy works, but again, not for about 40 to 50% of the people who participate. There's really no evidence that one therapy is better than another either. The choice tends to depend more on the therapist and what they've been trained in, or what they feel competent in, or what they think meets your needs best. Psychotherapy plus medications is definitely better than either one alone, again, for moderate, chronic, or severe depression. So what can you do if you have diabetes and you may also be depressed? First, you should talk to someone you trust. There's a quote here, there's no greater loan than a sympathetic ear. Talking to someone will not resolve depression, but it is a really important first step. And hopefully your healthcare provider is one of those people that you trust. But I would urge you to not wait for your provider to ask you, but to raise it directly yourself. Some healthcare providers are now screening for depression, which means they give you a little questionnaire to fill out. And if you score above a certain number, then they will talk to you about being depressed or potentially being depressed. But many providers don't do that. And even when they do, they have so many things they want to cover with you in your medical visit, they may never get there. So if you think you're depressed or if you're concerned about it, you need to raise it directly yourself. If you are prescribed medications, you should take them. Or talk with your provider about why you don't take them. We know there are lots of barriers to taking medications. You may just not believe in medication, or you may be concerned about side effects, or you may not have insurance. But if you don't want to take them for whatever reason, talk to your provider so that you can try to address that reason or come up with some other plan. It has to be a collaborative relationship. Similarly, if you're referred to counseling, go. Try it out. Go for like 2 or 3 sessions before you decide if you think it's going to be helpful or not. But if you don't want to go, then again, talk with your provider about why you didn't. Is it because you don't think it's going to be helpful? Or is it because you don't have insurance to pay for it? Or is it because you don't know who to go to? Work with your provider in a collaborative way to develop some kind of a plan. If you are being treated with medications and or psychotherapy and it's helping, then you should continue it until you're better. We also know that it's very common for people to stop taking antidepressants or stop counseling when they start to feel a little better. And the research shows that if you stop too early, you're going to get worse again. But on the other hand, you shouldn't be considering these treatments as something you have to do for life. In most cases, that's not the case. Some cases, maybe it is, but in most cases, it's not. So you want to be aware of the timeline and talk to your provider about that. If your treatment's not helping, then again, tell your provider and make a new plan. So what I'm really urging you to do is really actively work at addressing this issue. And then you can do the things that I've mentioned already to help yourself. Exercise is very helpful with depression. Eating a healthy diet, reaching out to others and getting the support you need. And then telling yourself that you can do it, trying to develop a sense of self-efficacy if you don't feel that you have it. And you can do this by setting small, realistic goals and then celebrating when you've achieved them, giving yourself a nice pat on the back and saying, okay, that was good. I did that. Now let's see what else I can do. And ultimately, you have to tell yourself that you're worth it. So this slide provides some more information or some websites that have more information about diabetes. The best one is the American Diabetes Association, the www.diabetes.org. It's lots of information. And then this provides some websites that provide more information about depression. And again, looking at NIMH, the National Institute for Mental Health, is a really good place to start. So I hope this information has been useful to you, and I wish you good luck in your managing your diabetes and dealing with depression if you have it. Thank you.